Now we are coming for the second speaker, Professor Jose Maria from Spain, and he is a professor of medicine and ethics, clinical director of ICU Hospital University, Virgin de Mauricio, Sevilla, Spain. I told it correct, Dr. Jose?
It is correct. It is correct.
Okay, welcome. And he is going to talk about the diagnosis of brain death. Welcome, Professor Jose.
First of all, I would like to thank the organizers for inviting me to be here. It is a big honor to share with the experience about that brain death diagnosis with so fantastic colleagues and excellent colleagues. So I would like to make some thoughts about why probably still brain death. It's a little point of a problem, no, in brain in the organ donation and transplantation. No? Probably most of you know well this doctor. No? It has been mentioned by Professor Doyle. No, is the Professor Christopher Barnard. No, in the cover of Time, because famous, very famous, because he made the first transplant, heart transplant. However, I don't know if some of you know these doctors. No, I am sure that most of you don't know them. No, because probably we know very well the transplant surgeons, but we don't know well who is the people behind the donation in the diagnosis of brain death. No, these are members, Professor Henry Beecher, Professor Schwabs, Adam, that were of the Harvard Medical School, the group of the Harvard Medical School who participated in the design of the criteria of brain death. Probably this still is a not very famous part of donation and transplantation. We can talk about death or brain death diagnosis, but the key question, and Professor Doyle has mentioned some people against the concept of brain death, against the implementation of brain death, is if death by neurological criteria is the death of the person. If the brain is the person. And that is the key, because all of us know very well that most of the organ, most of the cells, more of the tissues of the people in brain death are still alive. The key is if the person is dead and is the brain have enough substrate, organic substrate, for maintain the person. For thinking about this idea, I think we have biological, anthropological, and philosophical reasons. And I want to support some of these ideas. Biological reason for mention that the brain, that the person is in the brain. We can see this slide. How many people are in the slide? One or two? Probably most of you say two. Why? Because there are two heads, but not because there are two noses, because there are two brains. Anthropological reasons, of course. There are also anthropological reasons to explain why the brain, the brain is the key of the human being. We can see the evolution from the monkey to other hominid, to the person, to the human being. What is the main difference between the last one and the one before? The main difference is the brain, the capacity to thinking, feeling, to have vision of the life. And philosophical reasons. Of course, we don't have enough time in this session for talking about it, but only the brain of one person have possibility of immanency, what means the possibility of connection with the environment, the possibility of reception of information of the environment, and to transform this information in something useful for the mission of the life. Only the human being at the base is the brain have autofinality. We know what is our destiny in our lives. Indivisibility, we can cut different parts of the body, but only the part that maintain the brain is the part that maintain the real person, the completion. There are a lot of philosophical, anthropological, and biological reasons to maintain the idea that the person is in the brain. So usually we talk about brain death, but probably it's not a very precise way to express. Now, probably we should say diagnosis of death by neurological criteria. There are only one death, no different death. The key is the approach to death of the person is by neurological criteria instead of cardiocirculatory criteria, as we use in other circumstances also have been already mentioned. A concept that was coined in 1968, the Harvard Medical School, and also the World Medical Association accepted this concept. The definition of death, we can define of death in different ways, and the signs of death are different. Usually the cardiac arrest is the more classical way to identify the death of the person, the absence of movements, or even the maximum, the putrefaction of the body, and so on. This was the classical way of death: cardiac arrest, respiratory arrest, damage of central nervous system, death of the brain, death of organs of the body, putrefaction. But this classical way of death was changed by the development of the ICU, cardiopulmonary resuscitation. Only at this point we accepted that there are three main functions that are the frontier between death and life: the function of central nervous system, the cardiac arrest, and the absence of breathing. If there is a relationship between them, because some of them can start the other one. But nowadays, consequently, that the brain, the heart, and the lungs are the key organs for the life of the person. But nowadays we know that we can live without the heart. No? It's the heart of the recipient, of the donor, go to another recipient, and the person is the same with another heart. So the heart is not the base of the life of the human being. The same for the lungs one, the ECMO machine or transplantation of lungs. The only thing we can not make transplantation is the brain. And in the hypothetical case, we could make transplantation of the brain, the person goes with the brain. And what are the reasons for brain death diagnosis? I think that's very important. I have a list. One reason could be donation and transplantation. One reason could be the use of ICU bed for other patients to relieve cost of health system. But the real reason, the more important reason we must have, it is the last one: the dignity of the dead person, the dignity of this body that remains in the ICU connected to a machine, but the person is not dead. It's only the body. And a secondary value, it is the dignity of the donation and transplantation, the use of the ICU. But we, from the ethical point of view, must have clear that the reason for brain death is not donation and transplantation, but the dignity of the dead person, and after that, to add a new value. So, and it is also a point of reflection and the discussion in some countries in the moment. After diagnosis of brain death, we can decide it, well, we drop part of the treatment, continue the treatment, or cessation of the treatment. From the ethical point of view, because to maintain, again, the dignity of the person who died and the body who remained in the ICU, it is the cessation of all treatment. And the cessation of all treatment can be two ways: disconnection of the ventilator, if the patient is not going to be a donor, ventilatory disconnection, or circulatory disconnection, when it is down in the operating room for donation. So it is the best and the ethics activity after diagnosis of brain death: disconnection in the ICU or in the operating room. And now we are going to start with some of the problems that have been mentioned before. The problems of the different concepts of brain death nowadays in the world. Brainstem death was mainly coined by the Professor Christopher Pallis in UK, However, don't forget, this is the paper, Prognostic Significance of the Brainstem. For establishing that, we know the key is the absence of activity of irreversible loss of activity of brainstem, in this case. So brainstem death means absence of brainstem function, but cerebral hemisphere activity is possible. And the diagnosis is clinical and no instrumental. Second concept, nowadays it is decreasing, but in the 90s, was a flow of doctors who support the neocortical death. The supporters of this kind of concept, they say, what is most important for the human life? The content of the consciousness of some reflexes of the brainstem. And they say, this is more important, the content of the consciousness. So neocortical death, lack of activity of telencephalon, absence of neocortical function, subcortical and brainstem function are possible. The diagnosis is clinical, but clinical, no instrumental, of course, only analyzing the consciousness. Typical cases of the vegetative state, the permanent vegetative state of anencephalic. And the whole brain death, coined by Harvard Medical School, Professor Henry Beecher, absence of activity of brain, absence of activity of brainstem. So, absence of neurological function of central nervous system affecting the spinal cord. Cerebral hemisphere activity is not possible, and it is a difference between with brainstem. And the diagnosis is clinical plus instrumental. So it has been shown the different ways, the different problems, the different, each frontier means different practice in brainstem diagnosis, and probably it is one of the things we must improve. This is a big problem because one person could be alive in one country, cross the frontier, and is dead. But since the ambulance go back, the person is alive. So I think we have to manage this problem nowadays. This is the situation in Europe, for example, brainstem, whole brain death, Spain, for example, brain death, brainstem, Ireland or UK. So in any case, brain death is death. Brainstem death definition, whole brain death definition. I think we have to transmit the idea, the most important diagnosis. And one idea I think is also very important. Medical diagnosis, it doesn't mean medical diagnosis. We, as doctors, must be sure about the medical diagnosis. Only after that, we must know it fulfills the legal requirements of the country. No, in reverse, no first legal. First must be medical. After it, if legal requirements of the law. Who must establish diagnosis? Again, a point of controversy. One doctor is enough. Some laws, they say no, one doctor is not. Two doctors is better. Some laws, yes. Three doctors is better. Make no sense, because if three doctors is much better than one, so 25 doctors must be better than one. The key is not the number of doctors, is the qualification, the competence of the doctor regarding that. Important that. Irreversible damage, we have, for example, a big cerebral hematoma. Before the examination, of course, the patient must have normal arterial pressure. We must control the drugs that have been administered, body temperature, also you mentioned metabolic disturbance. Sometimes some classical topics, but nobody review that. For example, regarding metabolic disturbance, one classic idea, but without support in the papers. It is, for example, sodium higher than 160 is not compatible. It can mimic brain death. It's never have been published that, for example, no? For example. So I mean, also, so it is this aspect, that this prerequisite must be updated. We are using information of 20, 30 years old. Drugs that could interfere brain death. Solan, propofol, thiopental, the more classical in the ICU. We can solve the problem with an antagonist, or knowing what is the level of drug. For example, one of the classic topics, no, without effect of barbiturates, you can establish the diagnosis. Not true. people taking phenobarbital is walking by the street with therapeutic level. Of course, must not be established with toxic level. Of course not. But yes, we can establish with low therapeutic level. And there is a lot of paper that support that. No, this on some of the paper, the relationship of the concentration of barbiturates and the flattening EEG or the clinical examination. The other option, to stop the perfusion of the drug, and to be sure to wait 4 times the half-life of the drug. For example, midazolam half-life is 3 hours half-life, so 12 hours, propofol for maximum 4 hours, and so on. Brain death, absence of function, again, point of discrepancy. These are some of the activities based in the brain stem: photomotor reflex, corneal, oculocephalic, oculovestibular, motor responses, nausea, cough, oculocardiac, spontaneous breathing, or cardiocellular center. However, we can see that no, in all the guidelines are included. I still cannot understand why, because all the human beings, we have the same anatomy, the same function in the brain stems. I don't know why the frontier between one country and another country. I think my recommendation, do all of these reflexes, because all the human beings have the same anatomy. So it is the best way that we can be sure that the patient has no activity of the brain stem. This is the nucleus in the brain stem, pupillary reflex, we know well, the checklist, corneal reflex, okay, mesencephalum, advisable first the reflexes in the mesencephalum, oculocephalic reflex, or five phenomena. First, don't forget, in case of trauma, to check with X-ray cervical spine, open the eyes and move the head from side to side, and there is no changes. The eyes follow the movement of the head. Okay, this, for example, if we follow this protocol, we can discard the activity of mesencephalum, of the middle of the pons, and we have only activity of the lower part of the pons and bow. This could be one advisable protocol. Oculovestibular reflex, also included only in few guidelines, in few legislations. Check the tympanous membrane, put the head 30 degrees horizontal to put the semicircular channel, the horizontal semicircular channel in real horizontal semicircular channel, flash 50 milliliters of water to 4 degrees. And what happened in patient in brain death? Nothing. Forget nystagmus, quick movement, slow movement, forget, nothing happened. Motor responses, my recommendation to divide the clinical examination of the motor response in 4 parts. Why? Because there is, in some patients, as also has been mentioned, some spinal cord activity. So first step, the stimulus in the face, and the doctor look at the face. Impossible to see movement, trigeminus and facial nerve. A stimulus in the face, and we look at the body. Impossible to see movements. Because we are stimulating trigeminal territory. A stimulus in the body, and we look at the face. In the face, no movement. We are analyzing the 7th cranial nerve, the facial nerve. A stimulus in the body, and look at the body. At this point, we can find some movement. So it is a way to differentiate between the spinal cord reflexes and another kind of possibility. This one possible stimulus here. Don't forget, always try to use the first and the second roof of the trigeminus. From the corner to the mouth to the upper part of the ear. Up to this line, we are sure we are in the trigeminus territory. This is a frequent mistake. This is not the trigeminus territory. If the patient could have movements after stimulating here, you can see it is the second cervical spine root. This kind of movement, of course, it is important to know how to make the examination and even how to explain according to people who ask about this evolution. Checklist: nausea, cough, no cough, oculocardiac reflex. It is useful for analyzing the vagus nerve. We use it in the ICU, or we use it in the emergency department, because after an intense massage of the both eyes in a alive person, there is a bradycardia because the vagus nerve in patient in brain death, nothing happened. And now two centers that are also in the brain stem, in the bulb. Apnea test. This is protocol. There are different ways to do it. The key is to reach more than 60 millimeters of mercury, or 2 kilopascal, or 20 more than usual. Usually we breathe with 40 millimeters of mercury. Take a blood sample, first of all, to be sure to know how long must be the apnea test. Is that we know that it is 3 millimeters of mercury per minute of apnea. At the beginning of the test is 30. We have to wait 10 minutes to reach 60. With this average, it is good to know how long must be the apnea test. No evidence of breathing. An atropine test, of course, at the cardio accelerator center is in the brainstem. So the dose, as have been mentioned, 0.04 milligram, 3 per kilo, 3 milligram, 3 milligram. That in patient in brain death, nothing happened. We know 3 milligram, it is very, very high dose. Usually that the nurse in the ICU are reluctant. 3 milligrams, doctor, perhaps 1 milligram, no, 3 milligram. They know it's a very high dose. What happened in patient in brain death? Nothing happened. No increase of the frequency. This checklist. And now, question: is the patient dead? If we are using the concept of brain death, brainstem death, brainstem death means the death of the person, it is enough. If we are using the whole brain death, we still have not made the examination of the brain. We don't know what is happening with the brain. Like we cannot reach the brain through the brainstem because have no activity. So we need to use instrumental test for whole brain death, clinical plus instrumental test. Clinical examination, instrumental test. Clinical examination for whole brain death. We have to examine the brain. If not, we cannot talk about brain death if we have not made the examination of the brain. Recommendation: the 4 tests that have 100% of positive predictive value. None of these tests, non-tests have 100% of accuracy, but they have 100% of positive predictive value. These are mandatory, yes, for whole brain death. So, angiography, it is a very, very old test. You can see this paper of 1956 regarding this, describing this phenomena of no perfusion in patients with severe damage. Normal carotid territory. This is a patient in brain death. You can see here, stopping the carotid territory. These are arteries, the external carotid external artery. Normal basilar territory, normal perfusion. Stop the perfusion of the base. Only the vertebral, but not the basilar, the cervical. Or scintigraphy, dimension 99 by the HMA. Normal, normal. Patient in whole brain death, no perfusion of the brain, no perfusion of the brain stem, whole brain death, child. You can see here a patient with neocortical death, no perfusion of the brain, but normal perfusion of brain stem. So the activity, the brain stem examination, it is absolutely normal. A new patient in neocortical death, no consciousness, but still remaining activity in the brain stem, perfusion and clinical examination. And one patient in brain stem death. You can see examination, no activity if you analyze, but perfusion in the brain, still remaining activity. Or again, a new patient in brain stem death, no activity. So this no activity, no clinical examination, a normal perfusion of the brain. Transcranial Doppler, it is very frequently used in Spain. We have a lot of experience in our ICU. The evolution to the cerebral circulatory arrest, severe intracranial hypertension, but the patient is alive. The 3 patterns compatible with cerebral circulatory arrest: diastole-systole separation, reverberating flow, and systolic spikes. And we have to do analysis of the both middle cerebral artery and also the carotid artery. The limitation of cerebral blood flow test when there is a decompressive craniectomy, for example, therapeutic, or big fracture of the base of the skull, or Fontanella's periopen in children, or less accuracy, or EEG. EEG, this is a sign of a completely flat EEG. You can see the electrocardiogram, the movement of the thorax because of the ventilator, the control line. These are only three channels. You can see these spikes. These spikes are synchronous with the electrocardiogram. So you are detecting the electrical activity of the heart with the electrodes in the scalp, which means that there is no activity on the brain. Other tests with less accuracy, no 100% of positive predictive value, and UCT have no 100% of positive predictive value, so it is not recommended. False positive on angiography, or in this paper in intensive care medicine, limitation of computed tomography angiography in the diagnosis of brain death. Multimodal evoked potential was very useful in the 80s of the last century, but nowadays it is a auditory evoked potential, the evolution to come, changes in the weight form of the ICP, changes in the extraction of oxygen of the brain when the catheter is inserted in the jugular. This is so the recommendation to use one test that have 100 positive predictive value, EEG, mammography, Doppler, or SDF. You can see here, and we have to do only one of these tests. Of course, not all of tests. Children, I have no direct experience in children, but the task for 1987 were very similar to the task for 2011. Probably most of them recommend to repeat the test. And how many tests? Is it needed to repeat the test? When someone asked me about that, I asked again, how many times we can be dead? If they say one, so you have to repeat only one. If they say we can be dead two, you have to repeat two. Don't forget, the most important diagnosis, the key is the medical diagnosis, not the legal diagnosis. So if we do diagnosis of brain death, could you imagine all over the world in the way we have mentioned, all the reflexes of the brain stem, all the reflexes, and one instrumental test probably fulfill all the legal requirements all over the world. So it is my recommendation. Death is not a legal situation, it's a medical situation. And in any case, nowadays, you have to solve the problem. The three different concepts of brain death: whole brain death, clinical examination, instrumental test, brain stem, clinical examination of brain stem, neocortical death, only analysis of the content of the consciousness. So in any case, we know that it is a process of death. Sometimes we can see some phenomena close to brain death, the phenomenon close to brain death. The case was mentioned with Professor Doyle about a patient with breathing. Probably the deterioration, rostrocaudal deterioration still remain. No, it was not a false. No, he mentioned that. Probably we have to accept it is not at on of life, but of course we need a strict criteria, fulfill all the criteria. Is the biological criteria death of the person? I have no doubt about whole brain death is the death of the person because of philosophical, biological, and anthropological reasons. It's a strict protocol for the diagnosis of brain death. Only that, where I am in Sevilla. This is where I am. So, and these are my emails. So don't hesitate to contact me if you want to come to Seville or you want to know something about brain death and I could help. Okay. Thank you very much.
No, thank you so much, Professor Jose. And I think there is one question. And is the atropine test accurate? Does it has false positive results?
No. The atropine test, of course, it is also mentioned with the atropine test and the apnea test. Fortunately, they analyze elements of the lower part of the brain stem, and it is very useful because if you analyze from the mesencephalon pons valve, probably when you start this test, in some few patients can have a sleep alive and it remains. So the patient is alive because it still remains on some test. But in any case, it is that have no false positive or false positive because, and I recommended, and that is because I always recommend first the oculocardiac reflex, because the respiratory center, the cardio-inhibitory center, and the inhibitory center. So you do that. Don't. If you see bradycardia, don't proceed to do the other that. So it's my recommendation because I recommend always to do oculocardiac reflex. And it is not almost included in the almost any protocol, but I do recommend.
Yeah, for myself, I have a little bit confusion when you mentioned that there is some maybe persistent cerebral blood flow despite the clinical criteria of brain death. So how to clarify this area?
Yeah, because for brain death, the first point we must clarify is what concept of brain death we are using, what definition and consequently what criteria. And it is because it is important. So if it is very, very important, because sometimes we are talking that this is false positive, false negative. So the key is, if we are using the whole brain death concept, that I think nobody, I'm sure that none of us, nobody is against a whole brain death concept.
Yeah.
One of the problem it is usually you can find one patient with no activity of the brainstem, but can still have flow. Why? For example, hematomas of brainstem hematomas of cerebellum. What is the problem at this point? My point of view is this patient, the medical school UK said person in brainstem death are dead person. So in this case, but you have to admit that some of them have flow on the brain, because the concept and the protocol come from the definition. It is the first step to decide what is the concept. But if we use the concept of whole brain death, we have to analyze the flow. If we use the concept of brainstem death, we don't need to analyze the flow.
Yeah.
Because we are using in some patients brainstem death, and in another patient whole brain death. And I think, from my point of view, from the medical point of view, a medical school must do that. I think. And my recommendation, and now we are in the field of donation and transplantation field, is to use whole brain death. Because if you, not only for ethical, biological, and anthropological reasons, because the number of donors, if you analyze the map in general, the countries where it is used whole brain death, it is very similar to the countries with highest number of donors, because ICU doctors feel very comfortable, biological and ethically.
Yeah. Dr. Catherine, do you like to give any comment on Dr. Jose Maria talk? Just in 1 minute.
In 1 minute, a wonderful talk and a subject that I've noted. I mean, in Ireland, we tend to we sort of equate the two, whole brain death, but we actually tend, our confirmatory tests are predominantly blood flow tests.
Yeah.
So while we say we equate the two, we probably truly think in whole death tests, but we don't require people to actually do them. But we do require very strict radiological evidence of brain damage, which very frequently shows you no flow anyway in terms of what you see. So that's what we do. And whatever, I mean, I'm very confident when I complete my testing that the patient is dead if I have done all of my things properly. And one of the things that you'd be really careful about is the confounders, and make sure that you take your time. Make sure there are no confounders, that there are no drugs. Give them time. Time is not your enemy. Time is your friend here, to be absolutely sure of the diagnosis, because it's very important for the family and the donor that the procedures are done properly and you are confident of your diagnosis. And I think that's probably the best advice I've ever been given. There is no hurry. Your responsibility is to the patient in the bed that you have in front of you, and then to make that diagnosis accurately is very important.
All right. Yeah.
Okay.
Thank you.